start kar. Okay, fine. Okay. Okay. Hello, students. Okay. Hope you are doing fine. We got a slight delay from our side. Previous class is not completed, so we'll continue with yesterday's session. INI-CET Accelerate short series for PSM. Yesterday we completed some 25 questions, important areas, previous year questions, and this today also we'll see some 25 questions that is related with this previous year questions. Okay, fine. Now we'll start here. What is the answer, guys? Okay, what is the answer? Go here. Okay, which of the following will give you give the difference between lowest and highest? Okay, good evening Aditi. Okay, so which of the following will give the difference between lowest and highest score in the set of data? So this is related with measures of dispersion. Okay, so this is related with measures of dispersion. Okay, measures of dispersion. So the first measure, all are measures of dispersion only. So the answer is range. What is the range? Is maximum value. This is highest value to minimum value, that is range. So what is the range means? In a class, the maximum height is 185 centimeter per student is there, and the lowest value is 150 centimeter. Then you can say that, so the height in this class ranges from 185 to 150 centimeter, that is range. Second, what is standard deviation? Okay, standard deviation talks about deviation of data from mean. How much the data is deviated from the mean, that is given by standard deviation. How much the data. Okay, so what is the formula? I think in last 2 years there was some question. The SD, the formula is square root of summation x minus x bar the whole square by n. X bar means here mean. So summation x minus x bar the whole square by n. This is mean when n is more than 30. N means number of participants. Okay, there's one more formula is there. Okay, standard deviation summation x minus x bar the whole square by n minus 1 if n is less than 30. Okay, when to use n? So they won't ask calculation, so we should not be worried about it. So when to use n minus 1, this we should know. Okay, so n is more than 30 means use n. Okay, n minus 1 when n is less than 30. What is this variance? Yesterday we saw variance means SD square. Okay, variance. The fourth one, coefficient of variance. This is a measure of dispersion. Okay, recently I also asked question in INI exam. So the formula for coefficient of variance is SD by mean multiplied by 100. Okay, where it is used? Okay, this coefficient of variance, this is used for comparison of variation between groups. Suppose I have two group is there, so I want to check in which group there is more variation is there. For that purpose I can use it. Suppose I have a height. In a class I am measuring the height. So the height, mean height is 160 centimeter. Mean height is means average. Standard deviation is 5 centimeter, right? 5 centimeter. So you want thick pens, highlighters. Okay, fine. So height, mean height is 160 centimeter. and standard deviation is 5 centimeter. The notes we will pass it on, guys. Okay, the notes we will pass it on, and weight we will take weight. So the mean weight is 60 kg and standard deviation is 3 kg. Okay, fine. Now, can you tell me in which one there is more variation? This is coefficient of variance. This calculation itself was asked. Okay, so height is measured, you will say more height, but height is measured in centimeter, weight is measured in kg. So we cannot compare it. Then we have to apply this one. So we will calculate this 5. Okay, 5 by 160 multiplied by 100. So 500 by 160 is roughly 3.1 percentage. Here 3 by 60 multiplied by 100. This is what? 5 percentage. Okay. So which one there is more variation? There is more variation in the weight. Okay. This is called as coefficient of variance. Okay. So this is used to compare the variation between the two groups. Okay. Fine. Hope this is clear. If they are asking some form of problems, you should be able to do it, guys. Okay. Fine. We'll go to the second question. Again, another problem. Okay. Fine. In a study with a new treatment, there were reported 36 deaths out of sample of 120. The existing drug. With the new drug, there were 26 deaths out of 130. How many patients should be treated to prevent? It's not on death. It is one death. Okay, fine. So how many patients should be treated with the new drug to prevent one death? So what they are asking is, there is a concept called as NNT. NNT means number needed to treat. Okay. NNT means number needed to treat. This was asked the past INI exam question, number needed to treat. So NNT formula is 1 by ARR. ARR means absolute risk reduction. Is it not visible? Fine. Absolute risk reduction. Okay, fine. Is this okay? Fine. Yes. Now just check whether it is visible or not. It is absolute risk reduction. Okay, ARR means absolute risk reduction. So ARR means control event rate. Okay, ARR means so control group event rate. Now is it okay? Just tell me control group event rate minus treatment group event rate. Okay, fine. So ARR means control group event rate minus treatment group event rate. So they look here, they have done a RCT. For one group they have given a new drug. For other group they have given existing drug. Okay, so this is number needed to treat. We have to calculate here. So the formula is 1 by ARR. ARR means absolute risk reduction. It's a past question. Okay, fine. Now, so we'll go to the question now. So for the existing drug, so they treated with 120 patients. Out of them, there were 36 deaths were there. And for the new drug, there were 130 patients and there were 26 deaths were there. Okay, fine. Now we'll do the calculation. The control event rate is What is the control event rate? 36 by 120 minus treatment event rate, that is 26 by 130. This is ARR. If you do the calculation, this is 0.3 minus 0.2, which is 0.1. Okay, 0.3 minus 0.2, which is 0.1. 0.1. Okay, fine. So what is NNT formula? We saw NNT formula. The NNT formula is that, what we saw is that 1 by ARR. So 1 by 0.1, that is 10 patients. Okay, fine. If you treat 10 patients with a new drug, you can prevent one death. What is NNT means? Number of patients. NNT means number of patients to be treated, okay, with new drug for prevention of one bad outcome. Okay, for prevention of one bad outcome. Okay, this is NNT, guys. Number of patients to be treated, okay, with a new drug for prevention of one bad outcome. So in this question, if you treat 10 patients with a new drug, you can prevent one bad outcome. So okay, here the bad outcome is death. So if you treat 10 patients, okay, so one death we can prevent it. Okay, fine. Are you able to follow this? Okay, are you able to follow this? Fine. So we have seen two questions. One is related with the first one, biostatistics. Second one is this one, NNT. They're asking is NNT. Okay, where we will use this? This is we use in terms of RCT. We use form of RCT we will use. Okay, RCT. Two types of analysis we will do in RCT. One is intention to treat analysis. Intention to treat analysis. Okay, so include everyone in the analysis. What is this? Intention to treat analysis. Include everyone in the analysis, whether they are taking the drug regularly or not. Okay, so include everyone in analysis. That is intention to treat analysis. The second one is called as per protocol analysis. Okay, so second one is per protocol analysis. Okay, so include people who follow the protocol. Include people, okay, participants, if they are not regularly taking the drug means, so don't include their data in analysis. Include people, okay, who follow the protocol. Follow the protocol. Okay, these are the two types of analysis. One is intention to treat analysis. Second one is per protocol analysis. So in that you are going to see about NNT. Okay, so any method you can use this NNT, number needed to treat. Okay, fine. We'll go to the next one, guys. Next question. Absolute contraindication for copper T is that? Yes. So this is also a recent question, INI exam question. Is what is the answer here? What is the absolute contraindication? Okay, so what we are using right now is, in our program is copper T 380A. Okay, so this can be used for 10 years. Recently we started copper T 375, which we can use it for 5 years. Okay, 5 years, right? Now what are the contraindication? Absolute contraindication. Okay, so anemia is also a contraindication, but it's a relative contraindication. Okay, so answer here is, okay, previous history of ectopic pregnancy. What are the other contraindication? Absolute contraindication is, second one is vaginal bleeding of unknown etiology. Okay, vaginal bleeding of unknown etiology. Okay, fine. Okay, then we should then it is a contraindication. Vaginal bleeding of unknown etiology. Third, what else is there? What else is the other contra? Pregnancy, guys. Okay, if you have suspected pregnancy, okay, suspected pregnancy, okay, PID, pelvic inflammatory disease. Pelvic inflammatory disease, it's an absolute contraindication. And if you are looking for any cancer, CA cervix, uterus, adnexal region. So these are some of the absolute contraindications, guys. Absolute contraindication. Okay, fine. What is the most common side effect? Okay, what is the most common side effect? Yes, the most common side effect is most common. Okay, bleeding. Okay, bleeding. Most common reason for removal. Okay, reason for removal, it is pain, guys. Okay, so textbook of Parks says that, 27th edition says that. Okay, so most common reason for removal is pain, most common is bleeding. Okay, so there is ectopic pregnancy can also happen. Okay, so ectopic pregnancy is associated with the medicated device, that is progesterone. Ectopic pregnancy can happen with progesterone. Okay, ectopic pregnancy can happen with progesterone. Okay, fine. These are some of the points we should know. Okay, so other points you already know. Okay, so what is the mechanism of action? Because it causes a foreign body reaction and makes uterus unfavorable for implantation. And how long it can be used, we have already seen. What is 380 means? What is, okay, surface area of copper in square millimeter on the device. Recently we are using in the program, so already existing one is 380A, but recently we are using in the program is 375, copper T 375 we are using. We'll go to the next question, guys. Fine. This is another repeated question. Yes. Fine. What is this? Pick up the right answer when two screening tests are done in series. So the question is related with screening test. What is the answer here? What is the answer here? Yes, you can put it in the chat box. Right answer when two screening tests are done in series, guys. Series. So what is series means? Suppose I have two tests available, right? So test 1. Okay, test 1. I am applying it in a patient. So the result can be positive or it may be negative. Okay, a test 1. Okay, test 1 I am applying it in a patient. If it is negative means, okay, no disease. I am going to call this person as no disease. No disease. Okay, fine. The test 1 is negative means no disease, right? The test 1 is positive, then you have to do this person test 2. Okay, test 2, right? If test 2 is also positive or it may be negative. Negative means you are going to call this person no disease. Okay, negative means you are going to call this person as no disease. The test 2 is positive, you are going to call this person as diseased. Okay, fine. I'm repeating again. Test 1. Okay, suppose I have two tests available. Okay, two tests available. You do the first test. Okay, you do the first test. Okay, if it is positive, okay, for HIV you think, okay, so we do ELISA. If ELISA is positive, then you can go for confirmatory test. Okay, fine. So if test 1 is positive, do the second test. If second test is also positive, you are going to call the person as deceased. If anyone is negative, we are not going to call this person as deceased, right? Now, logically, can you tell me what will happen to false positives and false negatives? Okay, false positives alone we will see. Logically, if you see, okay, so you have to do two tests. The first test also has to be positive. Among them, you are going to do the second test. Second test also to be positive. So logically, if you see, there will be decrease in false positives. Logically. Okay, fine. Always remember, false positives and false negatives move in opposite direction. As a dictum, we can just try to remember it. Okay, fine. False positives and false negatives move in opposite direction. That means if false positives are less means there will be increase in false negatives. Okay, just keep it this way. Okay, so false positives and false negatives move in opposite direction. So there is a reduction in false positives. Let us assume that there is an increase in false negative. Now what they are asking here is what happens to sensitivity and specificity. So what is the formula for sensitivity? Sensitivity, the formula is sensitivity the formula is true positives by true positives plus false negatives multiplied by 100. What is the formula for specificity? Specificity is true negatives plus false positives multiplied by 100. Okay, fine. So both are, look here, sensitivity is inversely proportional to false negatives. Specificity is also inversely proportional to false positive. Okay, fine. Now what will happen here? Now what will happen? The true positives by what we saw here is this is what we saw here. This is what we saw here. So there is a reduction in false positives. Now what will happen? So if there is a reduction in false positives, so there will be increase in specificity. Okay. So there is an increase in false negative means, so there will be reduction in sensitivity. Okay, there will be reduction in sensitivity. So what is the answer here? Yes, this is the answer here. The increased specificity and decreased sensitivity. This is what the answer here. I'm repeating again. It's a simple concept. Okay, what is the concept here? So you are going to do two tests. First one test. If it is positive, do the second test. Okay, so ELISA positive, then you do the Western blot. Okay, for understanding we will take. Western blot is also positive. We are going to call the person as diseased, right? Now in this circumstance, you just think what will happen logically. So there will be chance of false positives will be less. I said that false positives and false negative move in opposite direction. So based on that, you can see the formula of sensitivity and specificity. Yes. Okay, fine. Hope this is clear. Hope you understood this. Okay, next question. Okay, so the iron folic acid dose for adolescent female under anemia Mukt Bharat. Okay, so what is the anemia Mukt Bharat? So look here, this is we are giving prophylactic iron, guys. Okay, prophylactic iron. The answer for this question is adolescent only, right? So 60 milligram of iron and 500 microgram of folic acid. So we are giving the adult dose we are giving. Okay, fine. Look here. So anemia Mukt Bharat. So 6x6 strategy. So what we have is 6 beneficiaries, 6 interventions and 6 institutional mechanisms we are going to do. So who is this beneficiary? These are the beneficiaries, guys. These are the beneficiaries. Okay, so these are the beneficiaries. 6 beneficiaries we have. So 6 to 60 months. Okay, fine. So you can say, you cannot say 60 months. So that is 59 months you can say. Okay, fine. Now, so here, okay, fine. Now 5 to 9 years, then 10 to 19 years. So this is what we are going to check here. This is what we are going to check. So for all these group, we are going to give prophylactic iron. For all these group, we are giving prophylactic iron. So now what is the dose we are going to give? So the people for 6 months to 59 months, 20 milligram of EI I will write, guys. Elemental iron, 20 milligram of elemental iron, and you are going to provide 100 microgram of folic acid, and you are going to give bi-weekly. Okay, bi-weekly. So twice weekly you are going to give. This is a prophylactic iron. So prophylactically you are going to give. So what type of prevention it will come? Yes, it will come in primary prevention. Okay, so prophylactically you are going to give. So 5 to 9 years, you are going to provide. How much you are going to provide? Okay, so 45 milligram of elemental iron and 400 microgram of folic acid. This you are going to provide weekly. In schools they will provide. So 45 milligram of elemental iron and 400 microgram of folic acid. For all other age groups, okay, for the remaining age groups, okay, so you are going to provide 60 milligram of elemental iron. Okay, elemental iron and 500 microgram of folic acid. Okay, 500 microgram of folic acid. So adolescents you are going to provide weekly. Women in the reproductive age group you are going to provide weekly. For pregnant women, when we are going to give? Yes, pregnant women when we are going to give? So pregnant women during from 4th month antenatally will start daily. Daily we are going to give till delivery. After delivery also you are going to provide daily for till 6 months. So you are going to provide from 4th month more than what? Okay, so during pregnancy more than 6 months, post pregnancy again 6 months you are going to provide. Okay, post delivery also you are going to give. Okay, and also we will do this deworming. So in deworming, whom we give, pregnant women also will give deworming 1 dose. Okay, 1 dose we will give in the 2nd trimester, guys. 2nd trimester will give. This is Anemia Mukt Bharat. Okay, Anemia Mukt Bharat. Okay, so am I clear? Fine. Hope this is fine. This is National Iron Plus Initiative or Anemia Mukt Bharat. So for children we give albendazole every 6 months once. 6 months we will give. So this is correct here. Answer for this question is this one. 60 milligram of iron and 500 microgram of folic acid. Folic acid. Fine. We'll go to the next question, guys. Okay. Answer this question. Answer this question. Yes, answer this question. Yes, what is it? What is the answer? Fine. Fine. Yes, the answer for this question is from the previous study, which among the following is the best choice? Okay, answer is meta-analysis, guys. Okay, answer is meta-analysis. Okay, fine. So look here. So meta-analysis, listen. These are some of the advanced form of study designs. Okay, we used for evidence-based research. Okay, so we have these 2 types we have. One is systematic review. Second is meta-analysis. Systematic review, what they will do is that they will systematically summarize. Okay, systematically summarize. Okay, summarize previous studies. Suppose we have some there's procedure is there. I'm not going deep. Suppose on a particular topic, suppose some 100 studies I am finding. Okay, 100 studies. So based on the criteria I select 10 studies. Okay, and I show the result in a graph called as box, this one. Okay, forest plot graph I can show. Okay, so 100 studies. So best studies I can select based on the criteria. So from that I can show the results I can show in a forest plot. There's a graph called as forest plot. Okay, fine. So meta-analysis is the next step. What is the meta-analysis we will do is that, okay, so in meta-analysis, suppose we have 100 studies on a particular topic. So you select the 10 best studies, for example, based on the criteria. So you make it as one value. This we call it as meta estimate. Okay, meta estimate. Okay, so on a particular topic, meta estimate. Okay, so the one value, convert all those results, odds ratio, relative risk, you make it in a single value. Okay, that is meta estimate. That is why it's called as best study design, because you are merging all the results and giving it as a single value. Okay, fine. Now this is meta-analysis. So what is the guidelines they are going to use? They are going to use this guideline, Prisma guidelines. Whenever you are writing meta-analysis, you can use this Prisma guidelines. You can use. If you're using for RCT, so for RCT you can use consort guidelines. Okay, reporting of RCT. So you can use consort guidelines. Okay, so we have a guidelines. So how to write a RCT. Okay, so it's a kind of checklist. So for meta-analysis, you can use this Prisma. For RCT, you can use this consort guidelines. Hope you understood this. We'll go to the next question, guys. Fine. What is this? Multiple time vaccine questions came. The viability of vaccines can be monitored with which of this? Yes. The answer is VVM, guys. Okay, you will know that. Okay, answer is VVM. vaccine vial monitor. Vaccine vial monitor. Can you tell me which stage you can use it, which stage you can discard it? Can you tell me which stage you can use it? Yes, VVM stage 1 and 2 you can use it. Stage 1 and 2 you can use it. Stage 3 and 4. Okay, stage 3 and 4. Okay, so stage 3 and 4 you can discard it, guys. Discard it. Okay, discard it. Okay, so outer square, inner dark circle will be there. Okay, so as dark means you have to discard it. What is the name of the test for frozen vaccine? To identify frozen vaccine, what is the name of the test we use? Okay, can you tell me the frozen vaccine? Frozen vaccine, the name of the test is shake test. Shake test. Okay, shake test. Frozen vaccine, the name of the test we can use is shake test. What about open vial policy? Okay, open vial policy. Okay, so open vial policy, you can use vaccines for 28 days. Okay, so you can use this vaccine for 28 days. Once you opened it, you can use it for 28 days. Okay, we are discussing the vaccines which is there in the national immunization schedule. Okay, so this is not applicable to, it is not applicable to which vaccine? This is not applicable to, there is some lag is there. Fine, we'll go to the next question. Now, a 30-year-old male came to OPD with history of diarrhea. ORS was prescribed. Okay, what is the use of, yes, okay, ORS, what is the use? Okay, so what is the use? Okay, sugar. What is sugar? Okay, sugar, the main use is that it enhances this salt absorption. Okay, it enhances this salt absorption, it enhances. Okay, fine. Now, so here ORS, we have this, we are dividing the patient into no dehydration. So no dehydration. Okay, where you are going to give home-based fluids. Okay, home-based fluids. Okay, rice water, dal water, those things we are going to provide. Okay, no dehydration. Some dehydration, you are going to provide ORS. Okay, so we are going to provide ORS. Severe dehydration, if the patient is having severe dehydration. Okay, so sunken eyes is there. Okay, not able to drink. Okay, so skin pinch test, 4, you will pinch in the abdomen. Okay, so thirst, general condition is very poor. Okay, so lethargic, kid is lethargic. Okay, in such circumstances, okay, so we'll go for severe dehydration. Severe dehydration is IV fluids. We'll use oral ringalactate. Okay, so we don't use normal saline. This oral will correct acidosis also. Okay, fine. So the question is with ORS. What is this ORS? ORS, if you take, okay, ORS, what we use is WHO reduced osmolarity ORS. Okay, so 245 milliosmoles. So we have to use 75 ml per kg in 4 hours. Per kg in 4 hours. After that, you have to repeat it. Okay, so you have to reassess the child. So 245 milliosmoles. When few years back, okay, when I was a student, it was 330. Okay, right now what we are using is WHO reduced osmolarity ORS, so 245 milliosmoles. Okay, and because it increases shelf life actually. Okay, fine. Apart from this, okay, apart from this, we can also, we have to give zinc also, guys. Zinc we have to give it for less than 6 months. Okay, we have to provide it for 10 milligram. We have to give it for 10 milligram. Okay, more than 6 months. More than 6 months, we have to provide 20 milligrams. So we have to give this for 10 to 14 days. It reduces the future occurrence of diarrhea. What is the use is that it reduces the future occurrence. Okay, so immediately for next 2 to 3 months, diarrhea, vomiting, it reduces, guys. Okay, fine. These are the points we should know regarding this one. Okay, fine. We'll go to the next question. It increases the absorption, guys. It increases the absorption. Next question. Severe acute malnutrition criteria is except. All are right except. Okay, the question is, what is the criteria for SAM child? Okay, severe acute malnutrition. So this is right. Edema, okay, is right. Weight for height below 3 standard deviation, this is also right. So this one is wrong. Okay, this is the criteria for a SAM child. Okay, so pedal edema is there, weight for height below 3 standard deviation, and mid-arm circumference. Okay, mid-arm circumference. Okay, we measure it between 6 months to 5 years. Okay, if it is less than 11.5 centimeter, or here they given is 115 millimeter. Okay, fine. Now, what are the indicators for acute malnutrition and chronic malnutrition? Okay, so we are going to use weight for age. Okay, weight for age and weight for height. Okay, weight for age and weight for height. This is wasting. Okay, so both indicates acute malnutrition. Acute malnutrition. And height for age. Height for age indicates chronic malnutrition. This is stunting. Stunting indicates this is chronic malnutrition. Okay, chronic malnutrition. So weight for age, weight for height, this is wasting, and height for age, stunting, this indicates chronic malnutrition. Okay, fine. Now, so in growth chart, what we are going to use? Okay, in growth chart, so we are using this WHO growth charts we are using. Okay, in Anganwadi. Okay, so we use this WHO growth charts. Okay, so it is plotted between weight for age actually. It is plotted between age and weight. Okay, age and weight, it has been plotted. WHO growth charts. Look here. Okay, this is median. From median minus 2 standard deviation. From median minus 3 standard deviation. Right? Any child is between median and this one, this is normal. So between minus 2 to minus 3 standard deviation, this is mild to moderate undernutrition. Okay, this is not SAM child, this is undernutrition. And anything less than 3 standard deviation, it is severe undernutrition. Okay, this is WHO growth charts we use in the programs. Usually growth monitoring happens in where? Okay, growth monitoring happens in a place, Anganwadi, guys, Anganwadi. So median to minus 2 standard deviation normal, and minus 2 to minus 3 standard deviation mild to moderate, less than that is severe undernutrition. Okay, fine. What is the answer for this question, guys? What is the answer for this question? Which are the following can act as a, okay, you can put it there. Which are the following as an amplifier host here? Amplifier host for Japanese encephalitis. Okay, fine. Japanese encephalitis agent. What is the agent? Okay, this is the answer here is pigs, guys, pigs. The agent is flavivirus. So the main reservoir for this Japanese encephalitis, what is the main reservoir? Okay, the main reservoir is birds and pigs. Birds and pigs. From that, it is transmitted to this mosquito Culex. Culex tritiniorinus, Culex vishnui. These are some of the mosquitoes. Okay, mosquitoes. And from there, it is transmitted to humans. So more common in which age group? Okay, common in children, guys. Okay, less than 5 years. Less than 5 years, it is common. Yes, fine. Less than 5 years, it is common. So birds and pigs, and among these, pigs are considered as the amplifiers. That means they won't show any signs or symptoms. amplifiers, and this condition is having a case fatality rate is little higher actually. So the case fatality rate is for this condition is 20 to 40 percentage. 20 to 40 percentage. What is very peculiar of this Culex is that, what is a very peculiar? Okay, yes, this Culex mosquito breeds where? Okay, the Culex mosquito breeds in paddy fields. So paddy fields, so that is why it is common in the rice growing areas. Okay, rice growing areas it is common. Okay, so paddy field water will be there. So it is, this breeding happens there. Okay, paddy fields. Now, what is the vaccine we give in our program? Yes, in these areas we are providing vaccine called as SA-14-14-2. This is the vaccine we are giving, live attenuated vaccine, guys. It's a live attenuated vaccine we are giving only in these areas. So dose is at 9 months. Again at 16 to 24 months we give. 2 doses we give. So 9 months again at 16 to 24 months. Okay, so this is Japanese encephalitis we are giving. Okay, fine. So this previously we used to give this. What is the vaccine previously we used to give? Previously we used to give this Nakayama strain. We don't give it now. So what we are giving is SA-14-14-2. Okay, fine. Answer the next question, guys. Okay, fine. This is a little tricky question. Okay, it's a big problem. Past they have asked this question. Okay, fine. But whether you are able to solve this problem or not, but I want you to remember one important concept here. So what they have given here is, okay, they have given sensitivity. Sensitivity they have given. They given specificity of 90%, and disease prevalence they say that 10%, and they are asking is positive predictive value they are asking. So what they have given is sensitivity 90%, specificity is also 90%, prevalence of disease is 10%. Okay, fine. Now we have to make some assumptions. Okay, formula I already told you, sensitivity and specificity. So we have to make a 2 by 2 table. So let us take that. Screening test, we will take it in the x-axis. Sorry, y-axis. Screening test, positive, negative. Diagnostic test, always you have to take it in the y-axis. So diagnostic test, positive and negative. Okay, fine. Okay, we have to make some assumptions here. This is what they have given to us. So sensitivity, specificity value they have given, and prevalence they have given, and diagnostic test. From that we are making. Okay, let us assume that. Okay, let us make an assumption there were 1000 people were there. 100 we will take. It's easy for us for calculation. Okay, 100. Okay, fine. So the total population is 100. So among them, what is the prevalence of disease? Yes, that is 10%. What is 10% of 100? Is 10. Am I clear? So out of 100, okay, so I'm giving 10%. Okay, 10% disease prevalence we have taken it. So how much is remaining? Okay, 90. This problem can be done another way also, but this I feel that this will help us to understand certain things. Okay, what is the formula for sensitivity? Formula for sensitivity is true positives by true positives plus false negatives multiplied by 100. This is the formula. Okay, so this is that true positives plus false negatives. Okay, so this is true positives plus false negatives, that is diseased people. Diagnostic test positive means that is diseased people. So we will substitute it here. So 90, that is true positives by, so 10 multiplied by 100. So true positives is, you do this calculation. So this is true positives is 9. Okay, true positives is 9. Fine, right? This is 9. How much is remaining? Okay, this is 1, guys. Okay, this is 1. Fine. Now we have to fill the remaining things. What is the formula for specificity? Specificity is true positives, true negatives, guys. Specificity is true negatives by true negatives plus false positives multiplied by 100. Okay, so this is that value. Okay, this is non-diseased people. This is that value. Okay, fine. So we will do the calculation here. So that is how much it is. So 90 is equal to true negatives by 90 multiplied by 100. So true negatives is, okay, so 90 by 90 multiplied by 100. So that is true negatives comes as 81, guys. Okay, 81. Okay, nowadays the mathematically they are not asking, but try to understand the concept. Okay, try to understand the concept. Okay, fine. Now, so this is true negatives. This is 81. Remaining is 9. Remaining is 9. Okay, fine. Now the question is, what is the formula for the positive predictive value? What is the formula for the positive predictive value? So the formula for positive predictive value is true positives, denominator is true positives plus false positives multiplied by 100. So 9 by 9 plus 9 multiplied by 100. So that is 50%. So that is 50%. So 9 by 9 plus 9 multiplied by 100. Okay, this is 50%. Okay, fine, 50%. So answer for this question is 50%, guys. Okay, answer is 50%. Answer for this question. Okay, so first you have to apply it. Sensitivity, from sensitivity you can calculate true positives. From specificity you can calculate true negatives. So based on that you can do. Okay, fine. Even if they are asking this problem or not, I think we have seen in last 2 years this question was there. But what I want you to remember here is listen this, positive predictive value. I want you to remember this one. Okay, positive predictive value is directly proportional to prevalence. That means if there is more prevalence of disease, means the positive predictive value will be more. This is the multiple times asked direct question. Okay, so this concept was multiple times asked. So the disease prevalence is more means positive predictive value will be more. Okay, fine. Whether you are remembering that or not, I don't mind, but make sure that you remember this concept. Next question. All of the following health indicators are covered under child screening, RBSK except. Okay, RBSK, everything was covered except. So what is this RBSK? So RBSK is for child screening. Okay, child screening and early intervention. Okay, child screening and early intervention. We are going to screen children between 0 to 18 years. 0 to 18 years. 4 Ds we will screen. Okay, defects at birth, deficiency disorders, developmental delay, and diseases, guys, and diseases. Okay, so these are the 4 Ds we are going to see. Defects, deficiency, developmental delay, and diseases. 4 Ds we are going to see. 4 Ds we are going to see. Okay, fine. Now, so let us see this one. Okay, so look at this. So defects at birth. We will see the question also. So you tell me what is the answer here. Let us see the defects. So cataract, is it there? Yes, it is there. Okay, what else? Vitamin A deficiency. Yes, we are going to screen. Congenital retinopathy of prematurity. Yes, it is there. What is not there is congenital glaucoma is not there. Okay, fine. Okay, congenital glaucoma. So congenital glaucoma is not there. So cataract we will see cataract, but glaucoma is not there. Okay, fine. So this is RBSK, Rashtriya Bal Swasthya Karyakram. As a program point of view, we do this. Okay, fine. So at birth, who will screen means existing manpower will screen. Okay, wherever the delivery happens. Okay, if the delivery happens in PHC medical officer will screen. Okay, so 0 to 6 weeks, who can go house to house? Yesterday we saw somebody is going house to house. Is okay. Home based newborn care is given by Asha. She will screen. Okay, 6 weeks to 6 years in Anganwadi they will screen, and after 6 years they will be screened in the schools. They will screen. Whose responsibility is screening? Okay, screening responsibility is PHC's responsibility. It is the primary health center's responsibility. Screening is the PHC's responsibility. Identify the correct statement about quarantine from the following, right? What is quarantine? What is isolation? Okay, 2 points we have to focus. Okay, what is isolation? Isolation we do on patients. Okay, isolation we do on patients. And how long will you do that? What is the purpose of isolation? So that they will not be transmitting disease to others. So this is during period of communicability. Period of communicability, right? Isolation, period of communicability. What about quarantine? I think we had a question in the last NEET exam also. Okay, quarantine. Quarantine we are going to do on whom? Okay, quarantine we are going to do on exposed people. Okay, so for COVID. Okay, so we thought that those who are exposed, we did quarantine. How long quarantine has to be done? Quarantine has to be done for the longest incubation period. For COVID, the incubation period is what? 2 to 14 days. So you have to quarantine for 14 days. Okay, so isolation, the question will ask in a different way. Okay, so remember that for COVID, okay, take the example of COVID. COVID, it is for COVID, what is it? COVID, it is 2 to 14 days. Okay, so if you want to quarantine somebody, you have to do it for 14 days. Somebody is entering into India, they are not having yellow fever certificate. Okay, the incubation period for yellow fever is 3 to 6 days. So you have to quarantine them for 6 days. Okay, fine. Now what about isolation? Isolation is on patients, period of communicability. I think we had a question on chicken pox, I think. The period of communicability for chicken pox is 1 to 2 days before and 4 to 5 days after rash. Okay, so after rash. So if you want to do isolation, it should be done during this period. So after 5 days of rash, it's not going to be useful. Okay, I think we had a question, same concept. Suppose if you take measles, what is the period of communicability of measles? So they won't ask direct questions. The question will come based on the concepts only. So measles is 4 days before and 4 days after the rash. 4 days after. Okay, 4 days before the rash and 4 days after the rash. Right. Now tell me what is the answer for this question. What is the answer? Right. Healthy contact. Okay, so answer is right. Okay, so restriction of movement of healthy contact of an infectious disease. Okay, fine. This is also a NEET INI exam question. Okay, we'll go to the last point. We will see calculate infant mortality rate. This was the question. Okay, calculate infant mortality rate. What is the formula for infant mortality rate? So the formula for infant mortality rate is infant deaths by live births multiplied by 1000. This is the formula. Infant deaths by live births multiplied by 1000, right? Now, what is infant? Infant means 0 to 1 years. Okay, we'll see the question. There were 456 births were there, out of which 56 were dead born. That means out 456 births, 56 were stillbirths were there, right? Now, the total number of deaths reported were 247, out of which 56 deaths happened in the first 28 days. So neonatal period is 0 to 28 days is neonatal period. So that is 56 deaths were there. Okay, fine. Fine, 56 deaths. Okay, 34 more died between, okay, so 28 to 1 year. That means post neonatal deaths. that is 34. What is the denominator? We include only live births. What is given there? Yes, what is given? 456 minus 56. So we don't want stillbirths also. So that is the only catch here. 400 multiplied by 1000. If you do the calculation, 90 by 400. Okay, fine. So this is 225, guys. This is 225. So 90 by 400, what we get is 225. So am I clear? So this is what it is. So this is infant age. So remember it. Okay. So the formula for maternal mortality, okay, infant mortality, neonatal mortality rate, for everything the denominator is live births, guys, live births. Okay, fine. So usually MMR we multiply it with 1 lakh for all other indicators, infant mortality rate, perinatal, neonatal, under 5, everything we multiply it with 1000. Next question. This is a past question only. The protein content of a human milk when compared to cow's milk will be. Okay, so the answer for this question is, okay, so in which one there is more protein is there? If you take cow's milk, it is rich in protein, energy, fat, calcium. So all are more in cow's milk. All are more in cow's milk. So answer for this question is human milk is 3 to 4 times less than cow's milk, the protein content. Okay, fine. So if you see, then what is the advantage of breast milk is that, so it is rich in, okay, so we have this cysteine is there, taurine, these are some amino acids that is rich human milk. Anti-infective factors are more. Okay, anti-infective factors are more. Okay, so it is rich in more amount of, okay, in breast milk. Okay, fine. It is more amount of iron with high bioavailability. So lactose is there, that is essential for the growing brain of the baby. Even vitamin A, D, C. Okay, so all are more in breast milk when compared to cow's milk. But protein, if you take protein, energy, fat, calcium, all are more in cow's milk. 3 times more. Exact value is 3 times more. Okay, the protein value 3 times more in cow's milk when compared to breast milk. What is this? So this is NIM stage is there, adult NIM stage. This is trans ovarian transmission is there. So that is seen in this mite, guys. Okay, mite. Okay, this is trombiculate mite. So eggs, larva. Okay, so that means what is this trans ovarian transmission? One stage of life cycle is infected. Okay, infection is carried from, what is this transstadial transmission? Infection from one stage of life cycle to another stage, that is transstadial transmission. That is mite, it is there. Okay, even ticks also it will be there, but this one is mite actually. Okay, so infection from one stage of life cycle to another stage of life. This is trombiculate mite, guys. This is trombiculate mite. Okay, fine. Now what is the disease it transmits? This trombiculate mite transmits, okay, scrub typhus. Okay, scrub typhus, rickettsial pox. Okay, rickettsial pox. Okay, scrub typhus and rickettsial pox. Trombiculate mite. Okay, fine. Can you tell me what is this vector? This has been asked as an image based question multiple times. Yes. Yes, this is what? Okay, good doctor. Okay, fine. This is Anopheles. Okay, Anopheles sits with an angle, guys. Okay, it sits with an angle to surface. No other mosquito will sit with an angle. This is the only mosquito that sits with an angle to the surface. Okay, so it breeds in fresh water. What disease it transmits? It transmits malaria. So the main disease, yesterday we saw, okay, some points related with malaria. This is the only condition, mosquito that transmits malaria in India. Fine. What about this one? Yes, this mosquito exhibiting hunchback. Okay, this is Culex mosquito. Hunchback will be there. Hunchback, no stripes. Stripes are there means it becomes Aedes, guys. So there is no stripes. Hunchback. It breeds in dirty water. It breeds in dirty water. What disease it transmits? Transmits filariasis. Filariasis and JE, guys. Filariasis and JE. Hunchback. There is no stripes are not there. Fine. Next. What is this mosquito? Fine. This mosquito. This is fine. Stripes are there. Okay. They exhibits hunchback. Hunchback. Stripes are there. Stripes are there. So this is Aedes, guys. This is Aedes. Okay, this is Aedes. It breeds in where? Artificial containers. Okay, it transmits in India. Dengue, chikungunya it transmits. Recently asked on is Zika virus. Okay, it transmits Zika virus also. Zika virus and dengue, chikungunya also it transmits. Chikungunya, fine, in India. Fine. What is this one, guys? What is this one? Yes, it looks like mosquito, but it's not mosquito. Okay, yes, this is sandfly, guys. Okay, this is sandfly. Okay. Slow mode, sir. What, I don't know what is the slow mode. Where is slow mode? Fine. So look here. This is sandfly. Sandfly, it transmits. Okay, fine. Sandfly. This is a hairy insect. Okay, this is a hairy insect. Okay, so sandfly. Okay, what is the disease? It is smaller than mosquito. Okay, it's smaller than mosquito. It has this lanceolate shaped wings will be there. Okay, so what does it disease it transmits? Okay, yes, it transmits Kala Azar, Oriental sore. One more that was asked, Chandipura encephalitis. Okay, Chandipura encephalitis. Fine. Fine. So am I clear? So this is sandfly, guys. This is sandfly. Kala Azar. Okay, Chandipura. It was asked as an image-based question. Okay, fine. So heart ticks, what disease it transmits? Heart ticks. Okay, heart ticks transmits KFD, Kaisunur forest disease. Okay, and babesiosis, tularemia it transmits. Okay, so heart tick. Soft tick transmits, you can remember like QR, soft tick. Okay, Q fever and relapsing fever. Okay, heart tick is K. So what is this? KFD and tularemia and babesiosis it transmits, guys. Okay, fine. Answer this question, guys. Answer this question. A medical camp was conducted among common people and screened for hypertension, and they are checking blood pressure and blood sugar levels. What type of prevention is involved? Okay, fine. So let us start with the answer for this question is, what is this primordial prevention? Primordial prevention. Prevention before onset of risk factors. If you do a prevention before the risk factor itself, then it is called as primordial prevention. What is this primary prevention? What is this primary prevention? So you are doing prevention prior to onset of disease. So you are doing prevention before the onset of disease. If you are doing prevention, that is primary. Okay, so the risk factor may be there, but you are doing prevention before that. Okay, fine. What is this secondary? Secondary means, okay, the disease have started. Disease have started. So action that halts. the progression of disease. So action, any action. Okay, so any action if you are doing that halts, that stopping the disease, so then it becomes secondary prevention. What is tertiary prevention? So tertiary prevention beyond that, measures taken to reduce disabilities. Okay, so any measures taken to reduce disabilities. Now tell me, what is this? What is the answer for this question? So any screening, understand, any screening is an example for secondary prevention. So for answer for this question is secondary prevention, guys. Secondary prevention. Okay, okay, fine, fine. I will do it, doctor. I will do it. Okay, fine. Fine. So measures taken to reduce disabilities, guys. Okay, measures taken to reduce disabilities. Okay, fine. So I'll inform the technical team because they have given the option. Okay, technical team. Okay, so they have to do it, guys. Okay, I'll let them know. Okay, fine. Now, so measures taken to reduce disabilities. Okay, so any screening means what is screening? Any screening is secondary prevention. What is the purpose of screening? The purpose of screening is to search cases. So it is a secondary prevention. Next question. The committee involved in village health planning is, okay, fine. So under NRHM, we have two important committees are there. Okay, National Rural Health Mission. The first committee is called as, okay, this one. The answer for this question is Village Health Sanitation Nutrition Committee. Okay, this has to be there. So who will be part of this? Panchayat people will be there. Okay, ANM, ASHA, okay. So NGOs, government official, all are part of this. Okay, fine. What is the purpose of this committee? Okay, this committee is involved in village health planning. This committee is involved in village health planning. Okay, they are planning for themselves. Okay, village health planning. So utilization of resources. Okay, so health promotional activities they will concentrate. Okay, construction of household toilets, health promotional activities they will concentrate. And this committee will celebrate village health day every month in Anganwadi. This committee will celebrate village health day. Village health day every month, monthly. Okay, monthly. This is the part of this village health sanitation and nutrition committee, guys. Okay, this committee. So recently asked question is these two questions were asked. Okay, this we have seen village health planning by this committee. There is no committee called as village health planning committee. So what is the committee we have is this one, guys. The village health sanitation and nutrition committee, and regularly they will celebrate monthly village health day. The second committee on NRHM is called as Rohi Kalyan Samiti. This will be separately for subcenter, PHC, CHC. It will be there. Okay, so this will be there. A subcenter, PHC, CHC. Okay, so these are called as patient welfare committees. Okay, patient welfare committees. So what is the use of this committee? Okay, this committee involved in utilization of resources. Suppose the money is entitled for a subcenter, so there will be members will be there. PHC separate members will be there. So they will be utilization of resources. Okay, money is coming, utilization of resources for patient welfare activities. Okay, patient welfare activities. Okay, fine. These are the points we should know regarding this Rohi Kalyan Samiti as well as Village Health Sanitation and Nutrition Committee. Okay, we go to the next question. What is the answer for this question? Yes, you should tell yes. Yes, this is for leprosy, guys. This is for answer is leprosy. Fine. Now, so we have these two drugs available, two types of leprosy. Clinically, we are going to diagnose a case of leprosy. One is that this is paucibacillary. So our program, National Leprosy, our program, so eradication program, so sorry, elimination program. So in the paucibacillary leprosy, and this is multibacillary leprosy, we are going to give. Okay, okay, multibacillary leprosy. Okay, fine. So for paucibacillary leprosy, we are going to give rifampicin monthly and dapsone. Okay, dapsone. Okay, this we are going to give it for 6 months. 6 months. Multibacillary, we are going to give rifampicin, okay, monthly, dapsone daily, clofazimine. Okay, clofazimine we are going to give daily. The rifampicin, okay, monthly, dapsone and clofazimine daily. This we are going to give it for 12 months. Okay, this is what our program mandates, and we have to follow these people. Okay, we have to follow this even after leprosy. Follow up is done for these paucibacillary cases. Okay, once a year for 2 years. So we have to follow them for once a year for 2 years. Multibacillary, you have to follow them once a year for 5 years. You have to do the follow up. Okay, this is what we do in our program. And for monitoring, similar to NICSE in TB, so we are having this NICUST we are having. Okay, NICUST. Okay, so for monitoring cases of TB, we have NICSE. For leprosy, it is NICUST actually. NICUST. Okay, NICUST. So what is the treatment for WHO recommends actually? WHO actually recommends, so rifampicin once a month, dapsone and clofazimine, all 3 drugs. Okay, this is given for paucibacillary for 6 months. This is what WHO says. For multibacillary cases, the same has to be given for 12 months. This is as per WHO norms. This is what WHO prescribes. Okay, so same 3 drug combination is given. Okay, 3 drug combination. 6 months for paucibacillary and 12 months for multibacillary. Okay. Dose of levonorgestrel used for emergency contraception. What is it? So this is given in the program under the name of easy pill, guys. This is given under the program under the name of easy pill. Okay, easy pill. Now, so what is the dose? So what is the dose? This is right answer. Is 0.75 milligram in 2 doses we have to give, and within 72 hours of unprotected sex. Okay, fine. Now, what other options available? This is the first option. The second option is you can give OC pills. Okay, so 4 pills you can give immediately, and 12 hours gap you can give 4 more pills. So the entire course has to be completed within 72 hours. Okay, third is OC pills with high estrogen levels. Okay, the estrogen content is a little higher. Okay, so this has to be given within 72 hours. Okay, this is OC pills with high estrogen content. And fourth one is you can give mifepristone. You can give mifepristone. Mifepristone. Okay, mifepristone you can give. This we call it as RU486. Okay, so this is single dose mifepristone. Single dose you can give. Okay, fine. Okay, excellent, Dr. Bhargavi. Okay, fine. Next, fifth is you can give IUCD. This is also 72 hours. IUCD you can give it for 5 days. Okay, IUCD alone you can give it for 5 days. Remaining all you can give it for 72 hours. Within 72 hours you have to give. Okay, following unprotected intercourse And this one program what we give is called as EC pill. Some other drugs we give in the program. What is this? Antara, we give it in the program. Okay, Antara injection is DMPA, depot medroxyprogesterone acetate. Okay. This is DMPA, Antara we give it in the program. DMPA every 3 months once we give. Next is Chaya. Okay, Chaya, this is also given. So this is called as, what is this? Okay, so this is ormeloxifene. Okay, so previously it comes under the name of Saheli. Okay, so non-steroidal oral contraceptive. Okay, it contains this ormeloxifene. Okay, chemical that is present there. Okay, Sencroman that comes under the name of Chaya. So it's a non-steroidal oral contraceptive. The chemical that is present is ormeloxifene. Next question. Last 5 questions, guys. Last 5 questions. A yellow fever vaccine which is valid for the following duration. So last year NEET also this yellow fever vaccine was given. So what we have is 17D vaccine strain. It is given. So the validity, they will be providing a yellow fever certificate. They will be providing yellow fever certificate. So validity starts from when? The validity starts from, so validity starts from 10 days to lifelong. Okay, so validity starts from, so the answer for this question is lifelong, guys. Okay, lifelong. 10 days to lifelong. The validity starts from 10 days to lifelong. And suppose yellow fever, somebody is coming to us not vaccinated, okay, but you are suspecting yellow fever. So the common question is related with quarantine. How long you can do quarantine for yellow fever? Yellow fever is 6 days. Longest incubation period. Okay, fine. So what is this IE strategy in yellow fever? Not been asked so far. IE strategy. What is this IE strategy? Is elimination of yellow fever epidemic strategy. Elimination of yellow fever epidemic strategy. Okay, elimination. This is what IE strategy is. Okay, I'm giving more facts. Some concepts, some facts I'm mixing here actually. So you know that. So yellow fever is not present in India. To avoid yellow fever entry into India, we take some measures. Okay, seaports and airports should not be any breeding place for how long? How much distance? Seaports and airports. Okay, no breeding for 400 meters. Okay, for 400 meters. Some salient points. Some salient points we are discussing. This is about yellow fever. Yellow fever. Okay, so mosquito is Aedes. Okay, it's not present in India. The case fatality rate is very high. Nearly 80% the case fatality rate. JE we saw that 20 to 40%. Yesterday we saw 100% case fatality rate. That is rabies. Next question is, what is this? In an African country, the vaccination was administered in an area of endemic outburst for a particular disease. Due to shortage of vaccines, mass chemoprophylaxis was given. So this one is which level of prevention is involved, they are asking. So we saw the different levels of prevention, right? So for that, okay, so these two, health promotion and specific protection, they focuses on primary prevention. Okay, early diagnosis and treatment, this comes in secondary prevention. Rehabilitation and disability limitation. Okay, these are some of the interventions actually. They comes in tertiary prevention. Tertiary prevention. The question here is, what is about mass chemoprophylaxis? Okay, the question is mass chemoprophylaxis. So look here, mass chemoprophylaxis means you are going to do, that comes in specific protection. So health promotion we will see. So how you can promote health? By education, health education. Okay, so you go to school, teach them hand washing, health education. Okay, you can do environmental modification. Okay, so avoidance of water stagnation. That comes in health promotion and weight reduction. Okay, so smoker, if the person is a smoker, if he is quitting it, that comes in health promotion before disease onset, right? And second is specific protection. Specific protection, these two comes in primary prevention, vaccines. You can give vaccines and chemoprophylaxis. Okay, iodization of salt, chemoprophylaxis, iodization of salt. You are wearing helmet, you are wearing mask. Okay, you are doing something very specifically for that condition. Okay, what is the answer for this question? Okay, so this is chemoprophylaxis. So which mode of intervention is specific protection? You are doing something very specifically comes in specific protection. So early diagnosis and treatment is secondary prevention, any case finding tool. Okay, we saw previous one. Okay, hypertension screening or pap smear screening or blood sugar, all comes in secondary prevention. What is the answer here, guys? It's also INI exam question. Program launched for increasing quality of labor room carries. So this is Lakshya, guys. The answer is Lakshya. Okay, fine. So we'll see one by one. So this is, what is JSSK? Okay, fine. What is JSSK? Janani Sishu Suraksha Karyakram. Okay, so this is related with free OPD, free blood, free transport. This program for pregnant mother and sick infants. Sick infants. Okay, that is JSSK, Janani Sishu Suraksha Karyakram. Okay, so they free OPD, free blood, free transport, free stay. Okay, so free diagnostic, they need not to pay anything. What is this Ayushman Bharat? Okay, it's a form of health insurance. So these provide a coverage of 5 lakhs per family per year. This is Ayushman Bharat. 5 lakhs coverage it provides. Pradhan Mantri Surakshit we will see. Okay. Some other terminologies we will see here. Okay, fine. So what is this Suman? Suman is Initiative for Zero Preventable Maternal and Newborn Deaths. Whatever programs are there, RMNCHA, okay, all these will come under this. Only thing is that we should not be doing no denial for services. We should be providing respected maternal care. Okay, so everybody has the right and we should provide this care. Okay, RCH, RMNCH, any act, antenatal care, intranatal care, postnatal care. Okay, so that comes under this Suman. Right, next. What is this Pradhan Mantri Surakshit Matrita Abhiyan? Okay, so people are coming very late for deliveries. Okay, they don't have antenatal checkup. So under this PMSMA, so 9th of every month, okay, free antenatal clinics will be done. Free antenatal clinics. Okay, any private practitioner can also be part of it. So they can go there and antenatal women can check. Okay, so whether they are having purpose is to identify high risk cases. Okay, high risk cases. So in MCH card they will mark the stickers. Okay, so red sticker means it's a high risk case. Green sticker means that is not a high risk case. Okay, fine. And we have this MTP amendment is there. So amendment Act 2020 MTP Act, there is an amendment they have given. So previously MTP was done for 20 weeks. So they increased from 20 to 24 weeks. Now they have increased, especially for the vulnerable group women. And previously up to 12 weeks, one registered practitioner opinion is fine. Now one registered practitioner opinion up to 20 weeks that has been raised. And 2 registered medical practitioners for any pregnancy for termination from 20 to 24 weeks. Okay, so between 20 to 24 weeks means So they require opinion of 2 registered medical practitioners. Okay, fine. These are some of the changes, guys. These are some of the changes we should know. And we have this Ayushman Bharat School Health and Wellness Ambassador Initiative. So we saw this RBSK and all. So 2 teachers in every school is designated as health and wellness ambassadors, and every Tuesday, okay, so dedicated as health and wellness days in the school. Okay, so 2 teachers are designated there and health and wellness ambassadors, and Tuesday, and they are actually involved, okay, for this Anemia Mukt Bharat visa. Okay, so they have to take this iron and folic acid tablet in schools. Okay, so that will happen under the supervision. That will happen. Okay. In management, which is more promising tool for application in health field? So we have these different tools are there. So cost benefit analysis. So this is a management technique. So you are comparing cost of the program with the economic benefits. Cost of the program is compared with the economic benefits, but that is not suitable for medical field. So I have invested some money. How much money I can get? So if you look in the program point of view, that will not be useful. So what will be more useful? Cost. Okay, so cost is compared with the effectiveness. Effectiveness in terms of what is effectiveness? Deaths and diseases prevented. Deaths and diseases prevented. This is more effective. This is more effective when compared to cost benefit analysis. Cost benefit analysis is not very much useful for us. So what is more useful is cost effective analysis. Okay? So to prevent one disease, to prevent one death, okay, how much cost? Okay, so that is cost effective analysis. We go to the last question, guys. Which are the following are the components of Kupusamy scale? The Kupusamy scale, this is used for socio-economic status. Economic status. So we use these scales. One is this Kupusamy scale. This is the first one. Second one is Prasad scale. Okay, so modified BG Prasad scale. Okay, modified BG Prasad scale, we use it. Okay, fine. Now, so for BG Prasad scale, the criteria which we are going to take is for BG Prasad scale, it is per capita income. Okay, income per person. Okay, income per person. Okay, that is BG Prasad scale. But what is used for Kupusamy scale? Okay, BG Prasad scale we can use in rural areas. Kupusamy scale we can use it in urban areas. Okay, fine. Now, so for a Kupusamy scale, we will see this. These are the table. So you can use this education of the head of the family, occupation of the head of the family, okay, and third one is family income. So based on this, we are going to use. So education, occupation, and family income. So what is the answer? It comes here. Okay, fine. Okay, so education, income, occupation, and education. Okay, income, occupation, and education. This is Kupusamy scale. Prasad scale, we use it in rural areas. We will use the last point here. This concept also recently asked from this topic of sociology. We have these different phases of family life cycle we have. Okay, we have this formation. Okay, so 6 stages we have. So formation stage is that. Okay, so marriage to birth of first child. Okay, so that is formation. Extension is birth of first child to birth of last child. You can link with your family. Okay, your father, yourself, as well as your grandparents also you can link. Okay, complete extension, birth of last child to first child leaves the home. That is complete extension. Contraction, first child leaves home, last child leave home. No children is there. Okay, so after that, and completed contraction is last child left the home and first spouse dies. And dissolution is that first spouse dies and death of the survivor. Okay, fine. This is the family cycle, family life cycle, and you can take your family as an example. You can take and you can go through this. So formation, extension. First child is formation, marriage to first child. Extension means first child to second child, complete extension. So that takes a long time actually. So birth of last child to the first child leaves home. Then contraction. First child leaves home to last child leaves home. Okay, complete contraction. Last child leaves home to first spouse dies. And dissolution means second spouse also. We can't say first spouse. Okay, death of the survivor. Okay, fine. So hope we completed this, guys. Okay, fine. So you can access us and Instagram channel. Instagram we have, okay, Facebook and YouTube channel, and be part of this Telegram group. So whatever we discussed today, this PDF I will share it in the group, guys. I'll share it in the group. Okay, fine. Thanks for listening. If you have any queries or anything, you put it in the chat box. Okay, and see you in the next videos. Okay, all the best, guys, for your exam. Thank you.